Impression objectives. Now let's see what are the objectives of making an impression. Classifying, there are 5 types of objectives that you need to keep in our mind while making any impression of the oral cavity. The first is preservation, retention, stability, support, and aesthetics, of course. Coming to the first one, that is preservation of the remaining tooth structures. Muller D. Van in 1952 stated that meticulous replacement of anything has to be thought after preserving of what is remaining. That is, whatever is remaining, we need to start preserving that rather than meticulous replacement of what is lost. So, preservation of anything which is there, like if tooth structure is present, preserve it, make help of the use of those tooth structures. If there is any bone present and it needs little more augmentation, let's do that. So whatever preservation techniques are there, we need to follow that before replacement of anything. Coming to the next one, that is support. How there is a big confusion here again. What is support? What is retention? What is stability? So make it very easy and understandable. Might think about this particular object. Now this object, if requires, I say you support this object. How will we support it? We will support it like this, right? So what we are doing, support means it is not allowing this object to go down. It is not allowing anything to give pressure vertically. So that means the masticatory forces are not allowed to act. So that will be called as support. So support is defined as resistance to the vertical force of mastication, occlusal forces and other forces applied in the direction towards the denture bearing area. So that is very well understood. How is support? Now, support as much as there is good for the denture. So how in maxillary, what is going to give us support? It is the hard palate which is giving us the support. So more the support, more the area for the support, less is the force distribution. How is that so? So force upon area, that is decreased. So force is decreased in one particular area since it is distributed in the larger area. So that is support. So now the similar waves, you have traveled any snow area. We have those snowshoes which is given to us, which is very big in size. What is the use or purpose of giving the snowshoes which is big in size? So the pressure on one particular area is decreased and it is distributed in a large area. So we will not slip down. So support will be better if we have a broader area. So that is the reason our denture, when it is on the hard palate, that effect is called snowshoe effect. That is the meaning behind it. So it is giving snowshoe effect is more concerned with the support. Coming to stability. How are we stable? Stability as in movement on horizontal direction. Movement of any object horizontally is stability. So once the object is not moving horizontal directions, that is called stability. So coming to the definition, as the quality and the quantity of the denture to be firm, steady and constant, to resist the displacement by functional stresses and not to subject to change of position when forces are applied. So that is how stability comes into picture. Coming to aesthetics. Aesthetics is the most important pertaining feature of any denture. A female patient coming to us is not mainly because he or she wants to get her teeth replaced because of mastication. It is more likely that she wants an aesthetic appeal, a look in the society which is appealing. So aesthetics is very important. Aesthetics are of many things. It is just not the placement of the teeth. Aesthetic is also concerned with the lip fullness. How is the lip fullness covered? If the denture flange is very thick, the lip will be more forwarded. So we need to keep the flange little thinner. The width and height of the sulcus. If the patient is having a short lip length is short and we have a denture bearing surface, the acrylic too low, then it will show us a gummy smile. Again, that is not aesthetically pleasing. So all these factors have to be kept in mind while preparing the denture concerned to aesthetics. Coming to retention. So we saw what is support, we saw what is stability. Now what is retention? If I ask this to retain this object, how will we retain this object? We will hold it from up. So retaining an object, that means we are not allowing the object to go down, resisting it from the upward motion. That means from any adhesive food like chocolates or anything kept in the mouth, from that the denture should not come up. That is a basic concept of retention. So it is defined as the quality of inherent in the prosthesis which resists the force of gravity, adhesiveness of the food, forces associated with opening of the jaw, basically opposite to the direction of the tooth. Any forces which is applied resisting that force is called retention. There are different factors which aid in retention. There is anatomic factors, there are physical factors, physiological factors, mechanical factors and muscular factor. Coming one to one. Anatomic factors, one which is created by Almighty. Size of the denture bearing area differs in maxilla and that of mandible. Told you earlier as well, 24 centimeters square is for maxilla, around 14 centimeters square is for mandible. So the maxilla stability will be more, support will be more rather than that of mandible, because the denture bearing area is less in case of mandible. Now, quality of the denture bearing area will also depend on the displaceability of the tissue covering over the bone. Cortical bone, fine, it is giving primary stress bearing area. But what about the tissue? The tissue is flabby, the tissue is reductant. So, submucosa and mucosa also plays a very important role in, like tissue rebound. We saw in rugae, it rebounds. Though it prevents the anterior displacement of the denture, the rebound nature of the rugae can be dangerous for the retention of the denture. Coming to physiologic factors, that is the saliva. Saliva also plays a very important and major role in the impression objectives for retention basically. So there are different types of saliva, we all know it is serous type, mucus type, mixed type. So which is a good saliva? Serous means thin saliva. So if there is a very thin layer of saliva, what will happen? It will not get interfacial surface tension. Mucus saliva, thick saliva, so it is giving more space, so it will automatically have no retention. So what is the best saliva for us? Mainly serous, but little of mucus. Why mucus? Because mucus has a property of sticky. So seromucus kind of saliva, which is more towards serous, is best for us. Coming to the physical factors. The different physical factors that are attributing to retentions are adhesion, cohesion, interfacial surface tension, capillary attraction and peripheral seal. Capillary attraction and peripheral seal almost the same thing. So adhesion. Adhesion is the property of any attraction of any unlike forces. Like for example, a denture and the mucosa. When there will be an attraction between the denture and mucosa, it will be seated in its position. So that property will be known as adhesion. Whereas what is cohesion? Between like forces. For example, in the saliva to saliva adhesion, attraction, that will be called as cohesion, right? For interfacial surface tension, there is another very important property which deals with the retention. What exactly is it? We try taking two glass slabs, put little water in it and try attaching both the glass slabs. Little water on one glass slab and attach both the glass slabs. It is difficult to take back the glass slabs. That property is called interfacial surface tension. So let one glass slab, you think about mucosa, the hard palate, one glass slab as your denture. So little saliva in between will not allow it to come out. So that's the reason that I was saying seromucus kind of saliva, more of serous, less of mucus kind of saliva will aid into interfacial surface tension. Coming to capillary attraction or peripheral seal, what is that? Capillary attraction, we all know, where there is less water, that side the capillary will act and the water will flow to that side. Down, the water will flow that side. Peripheral seal, now this particular seal which is created because of the denture and the mucosa at the end. Wherever there is an end, when there is a seal, a contact, a mucosa to denture perfect contact is present, that will not allow the denture to move up. So that is the reason every recording of the impression has to be done. It's in active phases. Like while we are talking about the muscles, we were talking about the frenum. I told you relief of the frenum was important but not wide enough, because that will remove the seal which is present by the capillary attraction or the peripheral seal. What will happen if there is a seal is broken? The air will entrap into that particular area. Once the air entraps that, the seal is broken, the denture will be out, the retention is gone. So that is one more important characteristic. Coming to mechanical factors. There are different mechanical factors that also aid in retention, like undercuts, but not all. So let's mention it as favorable undercuts. So favorable undercuts like mylohyoid ridge, like the undercuts present between the genial tubercles. Then magnetic forces, yes, at times when the flat ridge is present and we do not have any option, we can do magnet retained dentures as well. We have those, so that what happens is we can give the magnetic action to the denture so that it stays back in this particular position. We can use denture adhesives. Of course, we can use a gel form, we can use a powder form, so that those adhesives will help the denture to be in its particular place. There are different old schools of thought who still believe suction chambers and discs can be used, but beware of this particular thing. The reason is suction chamber or disc is not bad option to get a retention. That is the best option possible to get a retention in a flat ridge. But yes, what is going to happen bad with this is you will get papillary hyperplasia in the entire denture bearing areas. So once papillary hyperplasia is there, your denture is going to constantly irritate that particular area, which will cause the patient uncomfort, discomfort and pain, later on redness, bruiseness, and then it can go up to a pathological condition. So try and avoid suction chambers and discs. Coming to muscular factors, neuromuscular factor plays a very important role. If your muscles are active and it is well recorded by the impression, the time of impression making, then your muscle activity will not dislodge the dentures. But if your muscles are not active and it is very passive, even then it is good. But the only thing is the activity of the muscle, if once happen and not recorded during the impression, will dislodge all your dentures. So muscular factors is again important. Neuromuscular control anyways is important to aid in the retention of the dentures. Coming to the classification of impression materials and impressions. Different types of classifications can be there. What we have simplified the classification based on the theories of impression making. What are the theories of impression making? The earlier theory mucostatic, then came mucocompressive, then now it is followed by Boucher, that is selective pressure technique. Depending on the technique, it can be open mouth technique, it can be a closed mouth technique of impression. Depending on the particular tray that you are using, it can be a stock tray impression, that is a preliminary impression almost all the time. Custom tray impression, that is mostly the final impression. Case of fixed partial dentures as well goes the same. Their stock tray can be used for final impression as well. Depending on the purpose of impression, it can be a diagnostic impression, it can be a preliminary or a primary or a diagnostic impression, and a secondary impression. Primary impression is to make the custom tray for the secondary impressions, and secondary impression is to make the master cast for it. And also hand manipulation, which we should not forget, that is the border molding, or also known as peripheral sealing, done with the help of the green stick compound. Depending on the material used, what are the different materials that you can use to make an impression? We can use, starting from hydrocolloids, we can use reversible hydrocolloid, we can use irreversible hydrocolloid, agar and alginate respectively. We can use modeling plastics, that is the impression compound. Classification of impression compound only comes green stick compound, it is a type C impression compound. We have plaster, we have wax, we have silicone material, we have rubber based impression material, which is a newly impression material, and the impression material which is not mentioned here is one which has come up newly. There is a CAD CAM, that is with the help of the optical scanner we take it. So impression making, extent of the impression, what should be the extent of any impression? The edentulous upper impression should be made till what we had seen was till the behind the maxillary tuberosity. Now we need to cover till the maxillary tuberosity, and alveolar tubercle should be left behind because that will act as the limiting structure. What in the posterior palatal seal area, how much it should cover? So it should be behind 1 to 2 mm of the fovea palatini, and as well as till at least the anterior vibrating and the posterior vibrating line should be the limit of your impression making, as well as your denture at the end. Coming to edentulous lower area, what should be the limitation? The retromolar pad should be included and recorded well because it acts as a primary stress bearing area according to the new book. So coming to the ideal requisites of an impression material. So what are the ideal requisites that should be kept in mind to make an impression and the impression material that we choose? First and foremost thing, it should not be irritant to the patient. The smell should be pleasant. The impression material should be capable enough of taking the proper recording of the oral cavity. The impression material should be non-injurious, of course. It should not be irritant by any impression material. There should be no harm to the oral mucosa. There should be not injurious as well. There should be not post-reaction to anything. It should be sufficiently fluid when we are taking the impression inside the mouth, making an impression after that and then removing it back. The setting and the crystallization of the impression material should happen within that. Enough time should be given for molding the anatomical structures in its active position by the impression material. Then the impression material should be rigid after it is taken out, and once it is taken out, there should not be any dimensional changes in the impression material. So these are the different ideal requisites which are to be followed to choose which impression material we are gonna choose. Coming to the patient position, similarly, that where should we stand for maxillary impressions? We should be standing behind the patient or 11 o'clock position. For mandibular impression, you should come in front of the patient in 7 o'clock position. Coming of order of impression making. This is another depends from practitioners to practitioners. I personally believe of taking the mandibular impression first and then go ahead with the maxillary impression. I feel the advantage for that is in mandibular impression, once you're taking, the patient is accustomed to making of impression when you're making that impression. Whereas in maxilla, if you insert your tray first, then the patient can have a gag sensation. So to prevent that particular anxiety in the patient, which she or he will not allow you to take the mandibular impression, first better go ahead with mandibular impression and then you can start with the maxillary impression. Coming to the different theories of impression that we had discussed earlier was mucostatic, mucocompressive and selective pressure. Mucostatic, as the name suggests, is a passive impression technique. It was first proposed by Richardson, which was popularized by Henry Page. Now indications where all we use it, where retention is, our favorable factors are there for retention, where compression of the tissues are not required, where excessive flabby ridges are present. In those cases, we will go ahead with the mucostatic kind of impression. What material initially was used for mucostatic impression? It was impression plaster. What is the advantage of impression plaster? That it can record beautiful impression with impression plaster. But the main disadvantage is it is so flaky and brittle that once it is out and before even pouring the impression, it may break off. Another thing with impression plaster was if the mouth had a little more of saliva, your impression plaster setting time was increased. So the working time inside the patient or the setting time inside the patient's mouth was increased. So that can also cause discomfort. The taste, of course, is another big factor why it was discontinued. Coming to mucocompressive technique. Now mucocompressive technique are the places where you will compress the impression material, and yes, plaster of course cannot be compressed. So that cannot be used as impression material as a mucocompressive. So mucocompressive where you can compress the material, like in case of alginate, impression compounds, where we'll compress the material towards the tissue. And why we do that? To gain extra retention, right? Stability, support, all those factors. To gain that, we need to compress the particular material. Now, what was the disadvantage of this particular impression technique was impression compound or alginate when was compressed. The impression which was made was in a compressed form of the tissues. So the denture which will be finally fabricated will also compress the tissues. 24/7 compressing the tissues will cause the tissue irritation, will cause hyperplasia or cause other detrimental effects to the mucosa and the denture bearing area. So that's the reason we had to limit our use of mucocompressive impression. So there was a big question, big doubt and big researches which happened, and finally our Boucher sir came out with the selective pressure impression technique. What did he say about this? Since we had our anatomical landmarks which was classified as pressure bearing area, stress bearing area, relief area, supporting area. So why not we relieve the areas which are relieved? Why not we take maximum support from the area which are stress bearing areas? And why not we limit our dentures to the limiting denture base areas? So that is how the selective pressure technique was there. So the maximum pressure was given to the stress bearing areas. The relief area like the Brugge, like that of the incisive papilla. Why do we relieve rugae? Because it is a delicate structure. So though being a secondary stress bearing area, we need to relieve it. Otherwise, it will cause the mucosa, which is mucosal foldings, will get distorted. And impression material can cause distortion of that particular mucosa. So coming to the other two techniques, that is open mouth impression technique and closed mouth impression technique. So open mouth impression technique is a normal impression technique that we do. By opening the mouth, we do impression material, we mold the material, and that kind of technique which is normally done is called an open mouth impression technique. So why does closed mouth impression technique comes into picture? Closed mouth impression techniques are those techniques which is done by the patient himself or herself. That is like in case of neutral zone administration. What is a neutral zone? Neutral zone of the mouth is that particular zone which is surrounded one side with the tongue, other side with buccal mucosas, cheek. So there is one particular zone where the force of the tongue, vector of the force of the tongue is equalized by the vector of the force of the cheeks. So that particular zone, if we arrange our teeth, the denture will not get dislodged. So that particular is called the neutral zone. That is manipulated in the closed mouth technique. We make the patient to close his mouth and do the manipulation by himself or herself. That kind of technique is called the closed mouth technique. Hand manipulated functional movement, that is the border movements of the peripheral seal, or also known as border molding. That is shaping of the borders of any impression tray to confirm the accurate vestibular areas and the border seal areas. So that is also called peripheral tracing. That is also called border molding. Mostly done border molding with the help of green stick compound. That is a type of flowable impression compound. That is a type C. Or it is also done with the help of putty material. It is done with the help of even silicone impression materials. Coming to diagnostic impression. Diagnostic impression, or the preliminary or the primary impressions, are made to prepare the diagnostic cast, by which we can study, and through this we can make the custom tray, and that custom tray will be fabricated. Now what are the material of choice to do preliminary impression? The material of choice can be impression compound, it can be alginate, it can be your normal silicone impression materials. Impression plaster is obsoleted. Coming to secondary or wash impression material, the secondary impression material can be, first we do a hand manipulation of border molding on the custom tray which is prepared from the primary impression that we took. We make a cast out of it, and from the cast we make a custom tray. That custom tray is custom tray, that means it is customized to that particular patient. So on that we will do border molding, giving a 2 mm relief in the borders with the help of green stick compound, or with the help of, you can also do it with the help of putty material or polyether as well. It's a very newly and advanced material, and very good border molding is done with. It is a border molding is also classified into two types. Actually, it is the single step impression and multiple step. So in multiple or sectional, that we use border molding, that is we use green stick. For single step we use polyether. So there is a multiple step border molding done with the help of green stick, and then there is a wash impression which is made. Why we call it as a wash impression? Because it's only a layer of, like a water thin layer of material, that is secondary impression, is made to get adequate contact with that of the mucosa, the denture and the mucosa. So that can be used, light body can be used for that. What else can be used? Zinc oxide eugenol can be used for that kind of material. So we have shown you one with zinc oxide eugenol, and the other wash impression is by the light body. The material amount of the light body and that of zinc oxide eugenol will depend also on the spacer that you are using, not the relief. The spacer, relief is a different issue, spacer is a different. Relief we are giving to those areas which requires relief. Spacer is another wax, spacer wax we get, that you are supposed to use. Why do we supposed to use spacer wax? To get space for the secondary impression or the final impression material. So that will depend on material to material. Light body requires only 0.3 mm of space. Zinc oxide eugenol requires 0.5 mm of space. If we are using any putty material for secondary impression and also use at times, then we will require 1 mm of space. So depending on that, spacer will be decided. Coming to the other kind of impression material, it is reversible hydrocolloid impression material. So the next is reversible hydrocolloid impression material, which is a reversible hydrocolloid impression material which can be reversed. A hydrocolloid means something which requires water. Hydrocolloid, which forms colloid with the water. So reversible example, agar, as we all know. So agar is one of the reversible hydrocolloid impression material. What is required to make an impression with agar? We require a special water coolant rim lock tray, right? So what happens is when we are taking out the agar from the tempering bath, which is around 46 degrees Celsius, once we are taking it out, we need to pour it directly into the water coolant rim lock tray where water continuous supply is there, and then make the impression. Beautiful reproduction of the details are there of the mouth, that is up to 25 micron detail reproduction is there. So that is one advantage. Coming with advantage always is a disadvantage, that this agar material is not dimensionally stable. Why is that so? Due to, we all know, synergesis and imbibition, that is, it takes up water and it also releases water. So once it takes out, it swells up. Once it releases water, it shrinks back. So that is the disadvantage of agar. The next is irreversible hydrocolloid material. Name suggests irreversible, which cannot be reversed back. So like alginate. So alginate, which has an end product as calcium alginate, it is produced and we do not require any special tray. A stock tray, perforated stock tray is fine. But if you are using for a non-perforated tray, then we need to use adhesive. That is, alginate adhesive are available. So we need to use that. So alginate is one of the material which is used. Now for the alginate again, what is the disadvantage? Is the same due to synergesis and imbibition. Since it's a hydrocolloid, there is dimensional instability. But reproduction of details for alginate is the best again. Also, it gives a good peripheral seal. So coming to modeling plastic impression material. Modeling plastic impression material, for example, impression compound. Impression compound, how is that done? It is kneaded. It is put in a hot water of around 64 degrees Celsius and then it is kept so in parts and then kneaded back after it is removed. Uniform mass is formed, then you distribute it in the tray and then place the tray inside the mouth. Impression compound has a good viscosity and that is bad for us. Why is that bad for us? Because since it has a good viscosity, it gives pressure to some area which is unwanted. So we are compressing the tissues, and tissue compression should not be more. Reason being, in Boucher we found that he had a study which says only 9 minutes 54 seconds in the entire day when our mastication forces are applied. That is when the tissues are in the compressed state. Rest all the time the tissues are in relaxed state. So we cannot afford to have an impression or impression material which is compressing and making the impression. The next and newly advanced techniques and materials which have come over is silicon impression material. Now silicon impression material is further classified into condensation impression material or silicon and additional silicon. Condensation, as the name suggests, it is condensing form and some gas is released. We'll see what it is. So condensation silicon, condensation silicon, basically what happens, ethyl alcohol gas is released. It comes in a reactor paste and an accelerator paste. So we need to mix those two paste and make the impression. Coming to additional silicon either comes in cartridges or in tubes. Again, we need to mix it. If it is in a tube, then we have to have a gun to dispense the material and make the impression. Now, among condensation and additional, condensation doesn't have so much of dimension stability because of release of ethyl alcohol gas. Whereas additional silicon can be kept 1 week after making the impression without pouring. Unlike that of alginate, in alginate impression, that has to be poured within 10 minutes, not even more than 12 minutes of time that alginate is to be poured into a cast. Whereas an addition silicon can be kept for 1 week's time. Coming to the thiol rubber impression based material, that is also called the polysulfides. So thiol rubber based impression material, that is polysulfides, are formed in base and accelerator forms. So base and reactor, we have different type of tube, we mix it, and like zinc oxide eugenol, we mix it and then we place it. We can also get in cartridge forms. These polysulfides are basically a hydrophobic kind of material. So hydrophobic, phobia from water. So it should not be got in contact with the moisture. So what will happen? It will lose its dimension stability. The polysulfide material is also can be used mainly for the secondary impression. You know which kind of cases is more indicated for polysulfide kind of material light body is the mandibular thin ridge crest cases. In those cases where the undercut is present, a severe undercut is present and the patient is not ready for pre-prosthetic surgeries, so in those cases we can use the thiacol polysulfide impression material. Why is that so? Because of the elasticity of the material and the high tear strength. So once it is even inside the undercut, once you are removing it with one jerk, it comes out because of its elasticity and high tear strength. So the tearing of the material is also less. So that's the reason polysulfides are indicated in these kind of cases where there is a crest ridge is mandibular crest ridge is high, as well as where there is too much of undercuts present. Thank you.